Um, okay, so I'm just going to review the categories. The test will open after class, 11:40, be open till tomorrow at 9 a.m. So you have from after class today till it'll close at 9 a.m. tomorrow. So whenever you can fit in the test over the induction agents. And your homework was just to write up the drugs like we did the last time. The one category of drug that when I talked about induction agents, I said sometimes we'll use what's called a neuroleptal analgesic induction. Now, neuroleptal analgesia, all that means is that you combine an opioid and a tranquilizer. Now, if you do that in low doses, you can do this for sedation. Like if you do morphine and acepromazine, that's technically a sedative neuroleptal analgesia. But in certain cases, especially if you have a very debilitated patient, I've done hydromorphone and diazepam before, both IV. You have to give them separately, and in a higher dose, they can actually, and when I say induce anesthesia, our goal is, with sedation, they just had to be, diminished CNS, like they were sedated, but they still had reflexes. But induction of anesthesia renders the animal unconscious. And so we get muscle relaxation, and we get CNS depression, obviously depression of some vitals. But the goal with induction is to intubate and to render them unconscious. So in certain animals, neuroleptal analgesia can be an induction. Not a happy, healthy dog, but if you have a very debilitated patient, that doesn't take a lot of drugs. But let me talk about our primary injectable. And again, for the test, what is the goal of injectable anesthetics? To produce unconsciousness. The majority of them do not have analgesia, so you always need to know which ones do give analgesia. But the key here is when we do induction, if we're doing IV, you are giving the agents to effect. And that effect is I can open their mouth, I can intubate them, they are unconscious. Now, again, each of these agents last a different amount of time. So, this is like a bridge to go from sedated, which is stage 1, to get into stage 3. And stage 3, plane 1, is light. And then typically you're going to go on an inhalant, and that's going to keep the animal in stage 3. If you just use these one dose, you're not going to get a long amount of general anesthesia. So we usually use these to get the animal unconscious, intubated, and then move on to a maintenance agent. Sometimes you use these for maintenance. And next term, when we do canine feline anesthesia, I'll talk about that whole process more in depth. The first drug was propofol, and the key here is it's an ultra short acting non-barbiturate. It is also called a hypnotic, puts like in a state of almost hypnosis. So those are the two categories, but it's non-barbiturate. It is not controlled currently in Indiana. So even though it says here that some states are scheduled, currently it's not controlled, doesn't have to be recorded. And it can be used in a variety of species. The only thing I wouldn't recommend, again, not in horses, probably not in adult cattle. Number one, you'd have to give a very large amount. Number two, it doesn't hang around very much. And, with a horse, we need something a little more potent that's going to, that induction agent. And I get into that when we do equine anesthesia. So it's primarily for induction. You can do repeated bolusing, like either just keep giving them some propofol IV and use that to keep them asleep because it is non-cumulative. So the repeated, after the first dose is gone and you give the second dose, it's like giving another first dose. It doesn't accumulate in the tissue. So it is suitable for repeated dosing. Remember which drugs I told you you can do that with, and propofol is one. You can do it as a CRI, hook it up in a bag or a syringe and drip it in continuously, and that's the maintenance agent. The way you guys will mostly use propofol in practice is give one dose, intubate them, and then put them on their maintenance. There's definitely some keys that it is not very water soluble. It's an egg white base. It does have a milky appearance, but it is okay to use it IV. It's not clear. It looks like milk. It's all white. It's fat soluble, and it kicks in about 30 to 60 seconds. It renders them unconscious, but it only gives you about 5-10 minutes of true good anesthesia. So again, in about 10 minutes, propofol is going to be gone. So that's why you got to get them intubated and hooked up to the gas, unless you were just doing something that took 10 minutes. If you were like taking a quick x-ray or pulling out some stitches, sometimes we just give them a dose of propofol and wake them up. So it's very short, and dogs will be completely recovered, and cats in about 20 to 30 minutes. So it's a rapid induction, rapid recovery. And one thing, if I haven't stressed this, is I like propofol because I get rapid airway access. I'm always trying to get you guys in a mindset of, why do I pick one over the other? They will lose their swallow reflex. If I have an animal like a bulldog or a Frenchie that's difficult to intubate, I need a drug that renders them unconscious quickly and they lose their swallow reflex, because those animals are hard to intubate regardless. And I want to have a drug that's very potent, that allows me to intubate very quickly. And that's definitely, propofol is in that category. Lipid soluble. So again, it has an affinity for fatty tissue, which is why it goes to the brain, and minimal hepatic renal metabolism. So it's adequate for induction of those patients if they have renal insufficiency or hepatic insufficiency. No analgesia. If you give it, my keys here is, if you give it too slow or not enough, you can see some paddling, muscle twitching, and then all I have to do is push my propofol a little bit faster. Sometimes people say it's like seizure-like activity. They get these twitching. Again, this is sometimes used for animals we can't get out of a seizure. So it's, it would be rare that this induces a seizure, but sometimes people confuse the muscle twitching and fasciculations with seizure-like activity. Always check with your doctor. The one key here, it has a high tendency to cause hypotension. So it does cause, when you give it, it causes vasodilation. And anytime you dilate the vessels, you drop blood pressure. Now, when the drug starts to wear off, hopefully the pressures improve. But that's why you don't want to give it at too high of a dose or too fast. And if I have an animal, and this is how you analyze drugs, if I have an animal that has low blood pressure, I'm probably not going to pick this as my induction agent. It's not, going to be good for that. The other key here is that, it has a high likelihood of causing, I call it transient apnea. Now, apnea is associated with higher dosing and giving it too fast. But again, it lasts about 3 to 5 minutes. So it's not, permanent apnea, the animal would be dying. So I told you guys in lecture, how do I know the apnea is impending cardiac and respiratory arrest, or is it just the apnea from the drug? Well, hopefully I might have a little blink. I might have a good heart rate. Do I have good pulses? Do I have the dog after induction should have some muscle tone? But, animals that are too deep after induction, they get really flaccid right away. Heart rate plummets. Eyes are central. If the eyes are ventral medial, you have a decent heart rate, decent pulse, good color. It's probably just apnea or transient apnea from the drug. So that's how you tell the difference in the apnea if it's just normal. Some adverse effects is, and one thing on your drug, when you guys are writing up your drugs, and I needed to mention this, sometimes contraindications, everybody will put animals with known sensitivity, and that's literally the only thing they put. Well, yes, obviously if an animal is sensitive to a drug, you're not going to use it. There are plenty of other contraindications for every drug. So that's kind of a cop-out answer on homework, you need to put a little thought into it. I just told you with propofol, my main contraindications here is pre-existing hypotension, if they are allergic to eggs, if for some reason, you know, you have those things going on, that would probably be my contraindications to propofol. You can get some seizure-like activity at induction. Usually it is you're just not giving it fast enough or not enough. It is good muscle relaxation. It can cause some IV pain. When I start to give propofol, I just make sure who's ever restraining, I'm like, do you have the animal? Because sometimes they're relaxed and people get kind of relaxed with their restraint. I'm like, they can react when you start giving it. You have to be prepared for that. You cannot repeat doses in cats, meaning day to day. You can get Heinz body formation. Sight hounds can, you know, again, this is a good drug for sight hounds. So, you know, sight hounds can just be sensitive to anesthesia in general, but this is the induction of choice in a sight hound. I would definitely use, but it's usually seen if you're using propofol as your only maintenance, like induction and maintenance, and doing repeated. And again, it's not, if you think about this, it's not because the tissues are absorbing propofol that they stay deep. They lack fat, and some of the fat takes up this drug. So anytime an animal is lacking that fat component, so this could pertain to any lean patient, you know, then that makes more drug available to the brain. And then if there's more drug available to the brain, they can get deeper. So you have to maybe adjust your dose. Be able to explain how to give things to effect. I do not use this IM. I should really delete this. It's just not going to be well absorbed, and it's very unpredictable. It needs to be IV. So what you're going to do is I tend to give about half of what I calculated. So if I had 8 mils calculated, I would probably give 4 mils, assess the patient, and then I have 4 left, I'll give 2 mils. And then assess the patient, and I have 2 mils left, I'll give 1 mil. I half each amount that I have. You know, sometimes you have to give all of it. But there are there's been so many times where I've thrown away maybe half, sometimes 3/4 of my propofol. If they're really deep, you just give enough till you need. And what is the effect that I want? I want them intubated. I want them muscle relaxed. I want them unconscious. And the other key, highly protein bound. If you have an animal that has low protein, hypoproteinemia, you're going to need to lower your dose, because if you don't have enough protein for it to bind to, that means more drug is free in the bloodstream to be uptaken by the brain, and they can get deep. So you can give repeated bolusing, you can do a CRI, rapid recovery, and the key is, you know, I'll give you an example. Propofol's dose range is about 4 to 8 mg per kg. 4 mg per kg is if you have a patient that's maybe very relaxed or has a very good pre-med. 6 mg per kg is like a light pre-med, maybe they're a little crazy. 8 mg per kg, and sometimes I've even gone up to 10 mg per kg, is if I'm starting with an awake patient. So you can see, you almost have to double your dose if you're working without a pre-med. So it's definitely advantageous to, you know, part of pre-meds are anesthetic sparing. If you give them a pre-med, you should be able to use less induction agent, less of the offensive ingredient. You do have to shake and use aseptic technique, because then again, no preservative. It only lasts it's only stable for about 6 hours. It loves to grow bacteria. Now, I have sometimes used, and if you inject in a patient and you need more drug, sometimes people inadvertently pull the syringe out of the catheter, put it back in the bottle, draw out more drug. You've just had a needle in a catheter and you put it back in the bottle. Then I wouldn't use that bottle for any other patients. But you can, you know, we usually date and time our propofol and use it within 6 hours. And if it's on the counter and someone's already, you can see someone's punctured it, I wipe off the top with alcohol and then put a clean needle. Refrigeration does not extend its life. So you can't just say, oh, just throw it in the fridge. It's actually preferable to keep it at room temperature. It doesn't also minimize bacterial growth. So very strict. Etomidate, not as common. Cardiac, it's an ultra short acting non-barbiturate, but it's advantageous for patients that have pre-existing documented heart disease, mitral valve disease, cardiomyopathies, heart failure, things like that. So it has very little effect on the myocardium, like strength of contraction, blood pressure. It does have rough recoveries, sometimes vomiting is seen, and it does allow for repeated dosing. So again, on a test, think about the things that I tell you are key about this. Is not, like I said, I've only used this a few times. It's not, I don't like the recoveries with it, but if I do have a heart patient, you know, and sometimes patients that have heart disease have to have surgery, so that would be the drug of choice. Alfaxalone, which is Alfaxin, is another ultra short acting non-barbiturate. It's also called a neuroactive steroid. It's a steroid molecule. It's for induction. You can give it IM. It is off label IM, but you can use it, but it is controlled. So the difference between Alfaxin and propofol is Alfaxin is controlled. But you do have to record it. It's kind of, so it's a neuroactive steroid. It acts, you know, it's called an ultra short acting non-barbiturate. It's rapidly metabolized, non-cumulative. So it's very similar to propofol, but this drug is clear and this drug is controlled and it's more expensive. So those are the key differences from Alfaxin and propofol. But you give it the same way. Half of your calculated dose, half, give to effect. You get good CNS depression. And the other advantage, you know, if I'm going to justify, why would I pick Alfaxin over propofol? If I had 2 bottles in front of me, you know, cost could be an issue. You know, it's going to cost more. You have to charge the client more. So it could be a cost factor. But it has less effect on the heart rate, strength of contraction, and blood pressure. So it's a little bit better for the cardiovascular system. So when I said I had that hypotensive patient, I need to do anesthesia, I probably choose Alfaxin over propofol because it's a better, doesn't cause as much hypotension. You do see apnea. You can see some hypotension. It's not as, reportedly not as bad as propofol. And I have seen that in patients that I've used Alfaxin. But you can see apnea. Again, apnea is the higher dosing and giving it faster. The faster you give it, the higher dose you give, you're going to have a chance to see. But again, it's transient. It's the same rules as propofol. If you give it and they're apneic, you know, you intubate, check their other vitals, make sure their other vitals are stable. As long as their other vitals are stable, it's transient apnea. And then you tend to get the better relaxation without as much of the twitching. So again, it gives you about 10 minutes of good anesthesia. They wake up in about 20 to 30 minutes. They can get excited during recovery a little bit. It's not if you have a good pre-medded patient, then they tend to wake up better because some of those pre-meds will hang around after surgery. Now, if you have a long surgery, sometimes you have to top them off or give them a sedative. If they wake up crazy, sometimes we'll give them a little ACE or a little Dexdome or maybe some more pain meds. But again, you have to have strict aseptic technique. It does not have a preservative. And even though it's not white like propofol or has that base, it still does not contain a preservative. So 6 hours, and refrigeration does not extend it. Not to mention it's a controlled substance. So you're really not supposed to store it in the fridge unless you have a locked fridge, which most clinics do not. So technically, we just put it back in the drug cabinet. I time it, date and time, discard it within about 6 hours. And again, I told you in practice, Not everybody abides by that rule, but you're playing a little bit of Russian roulette in my mind. Now, the barbiturates, there's different classes. It's a big group of drugs, and they're classified by how they act. So a long-acting barbiturate is your phenobarb for seizure control. Short-acting is your pentobarbital, which is your euthanasia solution. The ultra-short-acting barbiturate is the anesthetic barbiturate that we use, and that is pentothal, which is known as thiopental. And the keys, there's not a lot on here. Now, this drug, some key things I told you, it is cumulative. So it is not suitable to keep like repeating. Like I never used pentothal as my only drug to keep them asleep. There's plenty of times I've just used propofol in a patient. That's all I've used. And I give them little doses to keep them asleep. If a procedure is going to be less than an hour, that's when I would do it. If it's going to be more than an hour, we would usually intubate and put them on anesthetic gas. The other thing, so this is controlled. It does accumulate in the tissues. It does require some liver and kidney metabolism, so you did need a good liver and kidney. It's not like propofol and Alfaxin, which require almost no liver kidney metabolism. The other thing, this drug is caustic to the tissues. If you get it out of the vein, like if the catheter slips and you see the vein blow up as you're giving the drug, you do have to infiltrate with saline, hot pack, because they could develop, a wound. And what it does is it kind of like, I don't want to say like it eats away at the tissues, but they will sometimes develop, they'll start licking the leg, lick granuloma, all of a sudden turns into an open wound. So you definitely need to flush the area. And again, this isn't commercially available anymore. The only reason I talk about thiopental is for the board exam, because more than likely they will ask you, because this was used like forever. Big category, but disassociatives, which the only one I talked about was ketamine and tilazol. Ketamine definitely has a lot of uses. It can be IM, it could be IV. The problem is it's not suitable to give it by itself for induction of general anesthesia. If I want to ketamine a cat for like a blood draw, a radiograph, to groom a cat, you could use ketamine by itself, but they're like a board. They're extremely rigid. So generally, ketamine is always mixed with something. Very rarely by itself. Now, tyletamine, you cannot find tyletamine by itself. Tyletamine is part of tilazol. Tilazol, now listen to the name, T-E-L, tyletamine, zol, zolazepam. Tilazol is tyletamine and zolazepam. It's kind of like an IM ket-val. So you're using a dissociative and a benzodiazepine, except it comes combined. It comes as a powder, you reconstitute it. It is a Schedule 3. Ketamine's a Schedule 3. Also, tilazol is used a lot in pigs. I like tilazol for aggressive patients. You can give them one shot in the muscle, and then they're completely anesthetized. I mean, I can intubate them, put a catheter. So that's really where tilazol has its advantage. Is for quick immobilization of an aggressive patient. Now, how do they work? Disrupt the neurotransmitter, like nerve transmissions within the brain. So you can get, some animals, they tend to look like they're in a trance. If you look at this picture, this is a very classic ketamine cat. A lot of times cats, when you give kitty magic, will look like this. They're just like, if I look at this cat, they look like they're looking at you, but they're in a trance. That's why I do this. Sorry, my dogs are being ridiculous in the background. So they tend to be very awake. Now, ketamine can be given, IM or IV are going to be your best route. Sub-Q is just unpredictable. But it's going to kick in a couple minutes, a little bit longer than propofol and Alfaxin. And then it's going to get 20 to 30 minutes. You're going to have a longer duration. But ketamine and tilazol both require liver and kidney metabolism. Now in the cat, if you remember, in the cat, 90% of ketamine is excreted as an active drug through the kidney. So again, I cautioned you is if you have a cat that has renal disease and the kidneys aren't, then potentially this drug is going to last. It's going to hang around longer. They're not going to clear it. I might use a different drug. In dogs, it's about 50%. So some of it's 50% of it's broken down by the liver, 50% is excreted unchanged. The definite differences, and this is something to stress, is that they retain their reflexes with ketamine. Now, when you give AJ, stop. Sorry. When you give ketamine by itself, they're gonna still blink for an extended period of time. They might retain a little swallow. Now, remember I said, if I have a dog that's hard to intubate, if I have a bulldog, and I have ketamine Valium, and I have propofol, which drug am I going to pick to intubate that dog? Remember, I got to get him intubated quickly. I have propofol, and I have ketamine Valium. Which one do I pick? Do I just go eeny, meeny, miny, mo, pick a tiger by its toe? I want to get him intubated quickly. One of these drugs, they retain their swallow reflex. One of these drugs, they do not retain their swallow.
So you use propofol, right, to intubate them quickly.
Yep. So your advantage, the problem with ketamine Valium, now Valium helps diminish those reflexes, but not like propofol. So the problem is, theoretically, an animal on Ket-Val may fight me a little bit during intubation. I mean, eventually I get the tube in, but I probably want to use the drug that's more reliable. So they lose the swallow reflex. That's, this is all about how do we pick one versus the other. So you're spot on. I want to choose whatever's going to get my animal intubated quickly. I don't need to be farting around. I have a dog that has compromised airway anatomy. I want to get a tube in. I want to get oxygen to my patient. So I'm going to choose the reliable drug. And that's an advantage. So they do retain some of their swallow. Their eyes remain open. Their eyes can get dry, so you definitely got to use the eye ointment, especially with ketamine. And again, once you get them intubated, these are going to wear off. Now, the key with ketamine or the dissociative is they tend to be more rigid. That's why you give it with Valium, with ACE, with dexdomitor, butorphanol. If you remember Kitty Magic is ketamine, dexdomitor, and like buprenorphine. Ketamine's the anesthetic in that combo. Buprenorphine's your pain, and dexdomitor is your sedative. You're kind of giving a pre-med induction all mixed together. That's what Kitty Magic is. It's a little bit of a pre-med, but it's also induction. Ketamine is facilitating intubation and making them unconscious. Because if you just gave them buprenorphine and dexdomitor, that's just sedation. You add ketamine to that combo, it becomes an induction protocol. And ketamine causes the but because you give the dexdome with the buprenorphine, that's going to enhance relaxation. Now, ketamine or dissociatives have analgesic properties. You still need to give them something. It's not enough for the protocol, but you do have some analgesia. That is a benefit. They're very sensitive to stimuli. They can be very bizarre, especially when you use ketamine by itself. They can wake up like, it's basically dissociative. It's like a hallucinogenic. When people abuse ketamine, because people abuse ketamine and call it Special K on the streets, they do it kind of like, maybe it's like acid or whatever. I don't know. I didn't do drugs. So it's supposed to do this like, so when they wake up, they're kind of there but not there. But they can act pretty bizarre. Now, you give it with other drugs, you will minimize that bizarre behavior. So cats can be nystagmus, and they call them tennis match cats. Like they act like they're watching something. Keys here, though, I always talk about the cardiovascular system. This group of drugs, actually stimulate the sympathetic nervous system. So you tend to see an increased heart rate, increased cardiac output, increased blood pressure. Now that sounds fantastic, right? I want a good heart rate, I want good blood pressure, except if I have an animal with pre-existing heart disease or tachycardia. I don't, if I have a hyperthyroid cat for a dental, I tend to stay away from ketamine because typically hyperthyroid cats have thickened heart muscle. They are usually tachycardic. And a lot of times they have high blood pressure. So why would I give them a drug that's going to make all that worse? So if I have heart disease in a patient, and this is obviously all up to the doctor, but generally, and for my test purposes, I give you scenarios. Why would I choose this one over this one? Well, if I have heart arrhythmias, I'm going to stay away from it. Remember, this causes this apneustic breathing, which is different than apnea. This is like they inhale and hold their breath. So they kind of go, and so sometimes when you're watching, it briefly looks like they're apneic, but that's why it's called apneustic. It looks like apnea, but it is not apnea. And that is normal with this drug, and it wears off as the drug wears off. So it's not like they breathe like that the entire surgery. Sometimes you just see it in the first 10 to 20 minutes, and then it should go away. And you can overdose. You have to be careful. This does not have a reversal agent. None of these induction agents have reversal agents. Now, stuff like propofol, alfaxin, they're going to wear off. Ketamine's going to hang around a little longer. So you can get an increase in salivation, and you can get increased intracranial intraocular pressure. So if I have a glaucoma patient, I don't use it. If I have a head trauma patient, I don't use it. And when you go to give it in the muscle, be ready. You can use it IMIV. It used a lot in horses, and I'll talk about that when we do equine. A lot of protocols have ketamine. You can use it for short procedures, chemical restraint. Ketamine is the most common, which is a Schedule 3, and normally IMIV, although you can give it orally, rapid onset. But again, repeated doses, it accumulates. So this is not appropriate to be used like give a dose, give a dose, give a dose. All those doses you give are going to accumulate, and you can get a very deep overdose. So ketamine's like a one-time, maybe I'll top them off once if I have to give a little more ketamine, but you don't want to use this as your sole agent. Ketamine Valium is the most common combo. You can give in the same syringe. I told you guys like 1 mil per 10 pounds. 1 mil is a half mil of each. So 1 mil is 50-50. But if I have a 20-pound dog and you need 2 mils, that's 1 mil of ketamine, 1 mil of Valium. You can mix ketamine, is the only thing you can mix with diazepam. Now, if you need to go in the muscle, remember you need to use midazolam because you don't give diazepam IM. But you can use ketamine midazolam, or you decide to use Tilazol. And Tilazol, it's great for pigs. We use it a lot in pigs and aggressive dogs. One shot in the muscle, they can get this apneustic breathing. It is IM, but again, rough recoveries. Okay, and that's where this this one stops. Oops. Sorry, let me. Okay, and then let me. All right, sorry.